Good afternoon. I'd like to thank the organisers, Scott Hanvey and Chris Nutting, for inviting me to speak today. So I'm a medical physicist. I've been working with the gamma knife for about 22 years. I was involved in the first double-digit MET treatment in 1999, and I've planned and treated up to 55 metastases in a single session. And probably been involved with around 2,000 metastasis treatments over that time. So first of all, I'd like to ask, is SRS for multiple metastases a reasonable treatment? How many is too many? We should be providing clinical efficacy. We should be providing a treatment that's safe, giving a low dose to normal brain. So we'll be looking at that. It shouldn't provide a disproportionate drain on staff resources, and it should provide good value for healthcare providers. So let's look at clinical efficacy. And I was looking back at some historical data. This is unpublished data from the Cromwell Hospital for a series of over 200 patients treated between 1998 and 2007. And please remember here that these are patients that didn't have access to the newer systemic agents, which undoubtedly would improve their survival. But if we look here at these patients and stratify them according to the primary disease, we can see that both breast and lung cancer, the median survival was around 15 months. When we divide the data according to the number of metastases, we can see that the single metastasis patients survive for around 16 months, 2 to 6 metastases, 12.7, and it's only greater than 7 where the survival seems to drop off, although newer data suggests that that's not so striking. It was RPA status which demonstrated the largest difference in survival between the three groups, with RPA Class 3 surviving just 5.3 months, but RPA 1 and 2 both surviving over a year. If we look at breast metastases only, we can see some very impressive results here. So for single metastases, that's the red line, the median survival was 29.5 months. For those with between 2 and 10 metastases, the median survival over 15 months. And even for those with 11 or greater metastases, we had a median survival of over a year. This is one of our very early success stories. This was a 40-year-old patient treated in the year 2000 with 10 metastases from breast. When we observed the lesions on the MRI scan on the day of treatment, we actually wanted to abort the treatment, but the patient persuaded us to go ahead and treat them. The total volume was 12.9 cc's, but you can see in the follow-up scan on the right, the patient was alive at their 11-year follow-up. So this was actually a very successful treatment. So SRS should be safe. It should deliver a low dose to the normal brain. And I've heard it said, well, if you treat 10 metastases with gamma knife, then it's a very expensive equivalent of whole brain radiotherapy. And that got me thinking. So I performed this small study comparing conventional whole brain radiotherapy, 30 Gray in 10 fractions, tomotherapy with an IMRT boost, 30 Gray plus 10 Gray. And then I found a tricky case, which you can see in the center of this slide. This was gamma knife treatment for 28 metastases, 18 Gray being delivered to each lesion. And then I looked at the dose volume histograms for these three different treatments. And we must remember here that the total area under each of these curves represents the radiation burden to the patient. So the lowest area is obviously better from a radiation protection point of view to the brain. So if we look at the whole brain radiotherapy from the LINAC, you can see that has the largest area, while the dark blue line representing tomotherapy with a 10 gray boost to the metastases, you can see that's actually a win-win, so it gives a higher dose to the metastases and a lower dose to the rest of the head. And we can see for Gamma Knife, it's significantly lower, about an order of magnitude lower in terms of the total area under the curve. Now you could say, well, Gamma Knife is a single fraction treatment while whole brain radiotherapy is 10 fractions. So let's look at one fraction of whole brain, and we can see here that the areas under the curves are approximately the same. So that would suggest that a single fraction of a very complex treatment for Gamma Knife for 28 metastases is very similar in radiation burden to a single fraction of whole brain radiotherapy. And we did a brain dose study comparing two different treatment devices, the old Model B Gamma Knife, which is no longer used, and a slightly newer Perfection Gamma Knife. And we compared the mean dose to the head, which is on the y-axis here, versus the total number of metastases treated in a single session. And you can see that the vast majority of these treatments deliver a dose which is less than 3 gray mean dose to the head, with the ones higher than that either being delivered with the older Model B Gamma Knife, or these patients had significant larger metastases. You can see here there's one patient that had 55 metastases treated in a single session. And if we summarize that data, we can see here that the mean dose to the head is just over 1 gray for the two different treatment devices, with it being lower for the Gamma Knife Perfection. Let's look at a clinical example now. This is a 53-year-old female diagnosed and sent to us with 5 brain metastases on MRI. The patient had a Karnofsky of 100. They were managed with radiosurgery alone for 114 lesions over 2 years, 8 months. And their Karnofsky of 100 remained for over 18 months. So on the first treatment, we perform a high-resolution T1 weighted MRI scan with a triple dose of multi-enhanced gadolinium, and this often does reveal more metastases. We were quite surprised to see over 5 times the number of metastases that were originally referred to us. But we went ahead and treated this patient, less than 1 hour to plan the treatment and about 3.5 hours to deliver the treatment. The patient then returns in April 2007, where we find 3 very small lesions that perhaps we missed at the very, very first treatment. The total volume of those 3 lesions is just 28 cubic millimeters. That took about 20 minutes to plan the treatment, about 30 minutes to treat. The patient returns in August 2007, where we treat lesions 30 to 38. The total volume just 0.29 cc's, about 40 minutes to plan the treatment and about 2.25 hours to treat. Then the patient returns again in December 2007, where we treat lesions 39 to 67. The total volume is 0.61 cc's. Less than 1 hour to plan the treatment and less than 3 hours to treat. And interestingly, during this scan, we were following up the previously treated lesions, but there were only 3 lesions from previous treatments that were still visible. The patient returns in April 2008, where we identify lesions 68 to 114 and treat all lesions that are greater than 10 cubic millimeters. The total volume is 1.8 cc, so very low, and takes less than 4 hours to treat the patient. Unfortunately, the patient succumbs to their disease in September 2009. So this is quite an extreme example. The patient didn't survive for a particularly long length of time, 2.5 years, but we did deliver 5 treatments during that time. So that's certainly much more than we would normally do. But this is an interesting example to see. You can see that the prescription dose for the lesions for each treatment was 25 Gray. The total number of targets, 114. The total volume of the targets was just 7.5 cc's, so relatively low. And if we look at the mean dose to the head from each of those treatments, they vary between 0.1 Gray mean dose to 2 Gray mean dose. If you add all of those together, it comes to 5.8 Gray. But these are 5 treatments delivered over a period of 15 months. So the biological effective dose will be much, much lower to the normal brain. Now, I've heard it said that if there are 10 lesions, there'll be 10 more when you do the follow-up scan. And using the data from the Cromwell Hospital, we found that 33% of patients were retreated with the Gamma knife due to new mets appearing. Now, we can ask the question, do the numbers of metastases at the original treatment predict the need for further treatment? Or we can switch this around and ask us, do patients that require further treatments present with more metastases in the beginning? And that's quite an easy question to answer. So if we divide those patients out into those that received just one treatment session versus those that received more than one treatment session, the number of metastases in each group is the same. It's about 5, and not statistically significant difference. But if we look at the survival, that's significantly different, with the patients receiving just one treatment surviving 10.2 months versus over 2 years, 25.4 months for those that receive more than one treatment. Here's another example of a patient with 6 metastases. The total volume here is 20 cc's, so that's just on the edge of what's acceptable according to NHS criteria. But the patient is alive with no further progression 12 years later. Create a treatment plan for the Gamma knife. I'm going to show you this case, which is a patient with 25 brain metastases, so a pretty tricky case. This one I actually planned manually using, manually placing isocenters, and it took about 25 minutes, which I was quite pleased with. But there's now a new convex optimization planning software available called Lightning. And this does the job much faster. So what I'm going to do now is show you the window where you can instruct the planning system what you want. So in this case, we want 22 Gray to all 25 metastases. If we wanted to limit doses to individual organs at risk, we could do that. But in this case, I'm not going to do that in this case, because this is a relatively simple case in terms of the metastases are quite a distance away from the organs at risk. So I click on Optimize, and this takes about 55 seconds in order to place isocenters on all of the targets. Typically we might see around 2 or 3 isocenters per target, which would correspond with somewhere between 10,000 and 15,000 beams. So this has just come onto the market in the last month or two, just become CE marked, and is now being implemented in Gamma knife centres in the UK. So we now have our treatment plan, and I can slowly scroll through the treatment plan, and you can see here the 22 Gray, the 12 Gray, and the 6 Gray isodose lines for the individual lesions that have been planned. Now, the elephant in the room is the difference in treatment plan quality depending on the platform used. There's a difference between gamma knife models, and I demonstrated that earlier, but there's a larger difference between different radiosurgical devices. And this has got to do with interplay effects, it's got to do with the beam energy used, it's got to do with whether margins are used or not, and sometimes the difficulty in planning many targets. And this was revealed quite nicely in 2016 when the RTTQA benchmarking study was performed, where all centres recommissioned by NHS England had to pass a series of QA tests in order to get permission to treat. The first benchmarking test was this one here, 3 metastases from non-small cell lung, 1 metastasis in the brainstem. The second case was 7 brain mets, and I remember at the time finding it quite difficult to persuade the rest of the team to include a case with 7 brain mets, but I think we would now accept that 7 brain met treatment is quite acceptable for SRS. And this shows the variation in selectivity and coverage and gradient index for the different treatment plans from the different devices, with some outliers here. There was also the parameter called the R50%, which is a very nice parameter that takes into account selectivity, that's the spillage of dose outside the target, combined with the dose gradient. And so the R50% is will normally be proportional to your 12 gray volume, independent of your target coverage. And we can see here a significant difference between the R50%, which is on the y-axis here, versus the target volume, which is understandable, and also the device used. And you can see a significant variation here. So the R50% varies from a value of about 3 to a value of around 15 for different platforms. Now, part of this is due to the different planning philosophies that are used, whether a margin is added, for instance, but part of it is due to the differences in beam energy and the different capabilities of each machine. Here we can see a significant difference in the normal brain V12 dose, which varies from around 5 cc's up to one outlier, which is 150 cc's. So we're not talking about a 5 or 10% difference here. We're talking about an order of magnitude difference sometimes between different devices. Another difficulty that we have treating metastases with SRS is when we are treating larger metastases, and this is data from the RTOG 9005 dose escalation study. This is a very old study with a number of flaws, but it's still probably the leading study in terms of influence on prescription doses delivered today. So here we can see the incidence of CNS toxicity from an 18 gray dose to a less than 2 centimeter diameter target, a 2 to 3 centimeter diameter target. And once we get above 3 centimeter diameter, you can see the incidence of toxicity goes up to 50%. We need to be able to reduce this somehow. One way that you can do that is simply lowering the dose, but you can see in this meta-analysis here that the 12-month local control decreases significantly as you reduce your dose below 18 gray. The other method that we could use would be fractionation, but the 12-month local control can be quite low if you're looking at, let's say, 5 times 6 gray, so that might not be the answer. And one of the methods that's been used a lot in the gamma knife community is staged radiosurgery for large metastases. This was originally proposed by Higuchi, and this involved delivering 10 gray in 3 separate stages with 2 weeks between each fraction. And the group found an 89% and 76% control rate at 6 months and 1 year, with significant volume reductions at the second and third treatments, with an adverse radiation effect at 1 year of just 16%. And this is the very first patient that was treated with staged radiosurgery. This was a patient with a 7.2 cc metastasis in the brainstem. Surprisingly, the patient had extremely good performance status, and it was decided to deliver 10 gray to this brainstem met and then retreat at 2 weeks. And here you can see the shrinkage between the first and second fraction. This includes follow-up scans. So at the top left, you've got the volume at the first treatment, 7.2 cc's. 2 weeks later, the volume had reduced to 4.8 cc's. We replanned and delivered another 10 gray, and you can see the follow-up at 8 months and 17 months. We've also used staged radiosurgery with great effect recently when you have a situation where the target is abutting organs at risk. So in this case, we've got a metastasis in the pituitary stalk, abutting the optics. During the first stage, we were only able to get subtotal coverage with 10 gray due to the dose to the optic apparatus, which we tried to reduce to 7 gray times 3. However, during the second stage, the target volume had reduced almost by a factor of 2, a 42% reduction, and that allowed the tumour to shrink away from the optic apparatus, allowing about a 0.5 millimeter gap. That allowed full coverage with 10 gray. And then at the third stage, the tumour shrunk even more, down to a 67% reduction, and by that point there was about a 1.5 millimeter gap between the optics and the target, allowing full coverage with 10 gray. This is a table with a small amount of data from a number of staged radiosurgery treatments divided according to primary disease. But we can see here that the relative target volume at the third stage is around 75%. And we must remember that with staged radiosurgery, there are 2 different effects going on. One is the target is shrinking, and as the target shrinks and we're able to adjust our dose, reduce our target volume, we're able to increase the gradient outside of the target. So we're sparing more normal brain. But also we must remember that tumour resistance is partly due to chronic hypoxia within the target, and by the target reducing in volume, we're hopefully getting some reoxygenation of the target, which will become more radiosensitive at the second and third stage. So we'd like to think that this is a win-win situation. With Gamma Knife, we're relatively new to the concept of using images which are not acquired on the day of treatment. But that's made us ask, how fast do tumours grow, and can we plan at leisure? So here's an example of a cerebellar met. You can see at day 0 it's 0.796 cc's. At day 14 it's almost twice the size at 1.447 cc's. That's actually the equivalent of between 4 and 5% growth per day. And that makes us quite nervous in the Gamma Knife community to use older scans. If we look in terms of maybe we could just add a margin to compensate for that growth, but you can see here that at day 0 the diameter is 7.8 cc's, at day 14 it's 13 cc's, so you need a 2.6 millimeter diameter to accommodate that. And also, we can't guarantee that tumours are going to grow isotropically. So in this case, the inferior portion of the target hasn't actually moved at all relative to the skull base, while the superior portion has actually extended 16 millimeters from its original edge. So summarizing now, from a historical perspective, if we look back 20 or 30 years ago, maybe we had CT imaging, maybe we only saw 50% of the targets that could have been treated. So that certainly wasn't an efficient treatment for SRS. 10 years ago, we had poorer MR imaging, maybe an 80% hit rate, but we also had inefficient treatment platforms, and that made it quite laborious to treat multiple metastases. Now we've got higher resolution, higher contrast imaging, and we're able to treat almost everything that we see. Maybe we're getting somewhere closer to a 95% hit rate. In the future, we'd like to see higher resolution imaging, better contrast agents to ensure that we get a 100% hit rate. And with an increased efficiency in treatment, we can treat absolutely everything that we see. So to conclude, I hope I've shown that focal treatment of maybe between 1 and 30 metastases is relatively easy with the Gamma Knife. Patients with many metastases, that's greater than 10, can be treated safely, often with good survival. Larger lesions can be treated via staged adaptive SRS instead of conventional fractionation. And finally, single-day scan, plan and treat protocol is probably ideal given the potential growth of tumours from day to day. Thank you very much for your attention.